Hello everyone, my name is Caitlin Kenyon, and I am a PGY2 Infectious Diseases Pharmacy resident at Hartford Hospital in Hartford, Connecticut. I worked in conjunction with Dr. Jennifer Gerardo, a clinical pharmacy professor, on this project. Today, I'm going to walk you through a summary of a blog post I wrote on an important topic in pediatric infectious diseases, which is on gram-positive resistance. The blog post I'll be discussing is titled Treatment of Gram-Positive Resistant Organisms in Children, Challenges and Current Strategies, which I wrote for the Pediatric Infectious Diseases and Immunization Update series, and you can find it on the University of Connecticut School of Pharmacy and Pharmaceutical Sciences website. As previously mentioned, the focus of this blog post, which you can find linked in the description below, is pediatric gram-positive resistance. Methicillin-resistant Staphylococcus aureus, MRSA, and vancomycin-resistant Enterococcus, VRE, remain two of the most important resistant gram-positive pathogens that pharmacists encounter. Since the COVID-19 pandemic, antimicrobial resistance has continued to worsen, making appropriate antibiotic selection even more important. One of the more interesting findings from a recent pediatric surveillance study comes from a national analysis of antibiograms across 46 U.S. children's hospitals. Approximately 1/3 of all Staphylococcus aureus isolates were methicillin resistant, meaning MRSA continues to be a major pediatric pathogen. The encouraging finding is that nearly 80% of isolates remain susceptible to clindamycin, although susceptibility varies considerably by geographic region. This emphasizes an important stewardship principle, and pharmacists should understand their institution's susceptibility patterns and select therapy accordingly. With that background, let's talk about perhaps the biggest controversy in pediatric gram-positive therapy today. One of the inspirations for this blog was a fascinating debate published earlier this year in the Journal of Pediatric Infectious Diseases Society, known as the Vanco Obituary Debate. One group argued that vancomycin's time had passed due to nephrotoxicity, therapeutic drug monitoring, infusion-related reactions, increasing VRE resistance, and the growing availability of alternative agents. However, a counter-argument was made to rebuttal that reports of vancomycin's death had been greatly exaggerated. Modern AUC-guided monitoring has significantly reduced nephrotoxicity compared with historical trough monitoring, and true vancomycin resistance among MRSA remains extraordinarily rare. In pediatrics specifically, vancomycin continues to be an essential drug for neonatal infections, invasive MRSA disease, and critically ill patients. The important takeaway is that the question in clinical practice is not, does vancomycin cover MRSA? The better question is vancomycin the best option for this pediatric patient? Fortunately, we now have more alternatives than ever before. These are several of the most clinically relevant alternatives that we as pharmacists should know. Each fills a different niche. Clindamycin remains an excellent oral option for susceptible community-acquired MRSA. Doxycycline has become increasingly accepted in younger children. Ceftaroline offers a unique advantage of being a beta-lactam with MRSA activity. Daptomycin is an excellent option for bacteremia as well as VRE, but cannot be used for pneumonia. Sulfamethoxazole trimethoprim serves as an oral step-down option in select patients. And dalbavancin provides exciting opportunities for long-acting outpatient therapy. Now let's briefly review the pearls for each medication. Many clinicians remain hesitant to use clindamycin because of concerns surrounding C. difficile infection. However, pediatric patients differ substantially from adults. Young children have lower rates of clinically significant antibiotic-associated C. difficile infection and higher rates of asymptomatic colonization. As a result, clindamycin remains one of the preferred agents for susceptible MRSA infections in children. Its excellent oral bioavailability, reliable tissue penetration, and activity against both MRSA and streptococci make it particularly useful for skin, soft tissue, and many musculoskeletal infections. Doxycycline has undergone one of the biggest practice changes in terms of recommendations within pediatric infectious diseases. Historically, tetracyclines were avoided in children younger than 8 because of tooth discoloration. We now know doxycycline behaves differently than other tetracyclines. Multiple studies have demonstrated that short courses, generally less than 21 days, do not cause permanent tooth staining or enamel deficits. Despite this, doxycycline should still primarily be reserved for mild to moderate MRSA infections requiring oral therapy, and should not replace standard therapy for invasive bacteremia or endocarditis. Ceftaroline is probably one of the most unique alternatives because it combines the bactericidal activity of the beta-lactam with MRSA coverage. It is the only beta-lactam capable of binding PBP2A, allowing the sustained activity against MRSA. Although FDA approval is limited, pediatric usage continues to grow for bacteremia, osteomyelitis, septic arthritis, pneumonia, and even some CNS infections. One important monitoring pearl is that prolonged therapy beyond approximately 2 weeks has been associated with neutropenia, making weekly CBC monitoring very important. Another interesting area is prolonged infusion with ceftaroline administration. Emerging pharmacokinetic data suggest prolonged infusion improved target attainment compared with traditional intermittent infusions, especially when treating organisms with higher MICs. With daptomycin, pediatric pharmacokinetics differ substantially from adults. Younger children clear daptomycin much faster, requiring higher weight-based doses to achieve similar drug exposures. Historically, daptomycin was avoided in infants younger than 1 year due to neuromuscular and CNS toxicity observed in animal toxicity models. More recent pharmacovigilance studies and clinical experience have not demonstrated those neurological safety concerns, making clinicians more comfortable using daptomycin when clinically appropriate. However, it is important to remember the major limitation of daptomycin, as it cannot be used for pneumonia because of pulmonary surfactants inactivating the drug. Trimethoprim sulfamethoxazole remains an option for oral step-down therapy, particularly for community-acquired MRSA musculoskeletal infections. There is, however, a theoretical concern that thymidine released from damaged tissue may overcome the drug's mechanism in deep-seated infections. Therefore, many clinicians still favor alternatives for invasive disease. Dalbavancin is one of the most exciting newer agents in pediatric infectious diseases. Its extremely long half-life allows treatment using a single infusion or 2-dose regimen, making it particularly attractive for children who need prolonged IV therapy but who wish to avoid long-term central venous access. Emerging pediatric case series have demonstrated excellent outcomes for osteomyelitis, endovascular infections, and deep gram-positive infections. However, pharmacists should remember that dalbavancin should not be relied upon for VRE because it depends on the resistance genotype, and most United States VRE isolates carry VAN-A-mediated resistance, rendering dalbavancin ineffective. Ultimately, I do not think the message of this presentation is that vancomycin is outdated. Instead, pharmacists should now have more tools than ever before. The challenge is understanding which patient benefits most from each option. Vancomycin remains an excellent choice for many invasive MRSA infections. Clindamycin and doxycycline continue to have important oral roles. Ceftaroline provides a valuable beta-lactam alternative. Daptomycin and dalbavancin continue to expand our options for complicated infections. The future of antimicrobial stewardship isn't choosing the newest drug, it's choosing the right drug for the right pediatric patient. Thank you for watching. If you found this video interesting, please be sure to like, follow, and subscribe to our channel, and check out our blog for more pediatric infectious diseases and immunization updates. Have a great rest of your day.